Okay, so hello everyone and welcome to Module 6, Part 1. And for today's topic, we are going to discuss about the Schizophrenia Spectrum disorders. So this is now our last week or of the last leg of our video lectures, and I hope really you have learned a lot about abnormal psychology, learn about the signs and symptoms, learn about how to spot them somehow, and I hope that these lessons that I have given to you will always remain in your heart. So without further ado, let's start with our lesson with Schizophrenia Spectrum disorders. Firstly, what is schizophrenia? So schizophrenia is a disorder characterized by disordered thinking, in which ideas are not logically related, faulty perceptions and attention, a lack of emotional expressiveness, and disturbances in behavior such as a disheveled appearance. They also withdraw from other people and everyday reality. They also experience delusions and hallucinations. So, substance use rates are also high. Suicide rates are 12 times more likely to die of suicide. And mortality rates are high as or higher than people who smoke. And there is 1% life prevalence that affects men more than women. So this disorder is diagnosed more frequently among some groups, and they usually begin in childhood, usually appears in late adolescence or early adulthood, and it is earlier in men than in women. And there is also a late onset, usually in the 30s, which is usually a more severe form of schizophrenia. Some scientists argued that schizophrenia is a neurodevelopmental disorder. It's because they said that the onset usually of schizophrenia starts at childhood, but it comes in phases. So the first phase is the prodromal stage, in which it consists of non-specific symptoms such as lack of motivation, social isolation, and difficulty concentrating. And then during the active phase, which is usually the active symptoms of schizophrenia is appearing during the late adolescence or early adulthood. So this is where they notice psychotic symptoms such as hallucinations and delusions. And of course, after that, there is the residual stage wherein there is no active symptoms of schizophrenia. There are no positive symptoms of schizophrenia. But of course, it will continue or cycle again back to the prodromal stage. So that's why scientists or doctors argue that they consider schizophrenia as more of a neurodevelopmental disorder because of the onset of it, the early onset of it in childhood, rather than an independent cluster of syndromes. But if you notice in the placement of the disorders in the DSM-5, after the neurodevelopmental disorder comes the schizophrenia spectrum. So you can see the connection of those disorders. So after neurodevelopmental, they recognize that the importance of childhood onset, and then schizophrenia, which is more also in the adolescent stage, early childhood onset stage also. So then bipolar disorders are next. So if you see the patterns there in how they place the disorders. Okay? So that is just one explanation of the schizophrenia spectrum disorders. So of course we have the different symptoms of schizophrenia, because schizophrenia, like I said, is a syndrome. They are a group of symptoms. Okay, so schizophrenia has a wide range of symptoms, and not all symptoms may be present in all forms of schizophrenia. The signs and symptoms of schizophrenia are usually divided into two categories: the positive symptoms and the negative symptoms. And there is now also a third category, which is considered the cognitive symptoms. It's also included in some descriptions of the disease. Both positive and negative symptoms are further characterized as motor, behavioral, and mood disturbances. So, just remember that there are three major symptoms of schizophrenia: positive, negative, and cognitive symptoms. So let's now move on to the positive symptoms of schizophrenia. So positive symptoms of schizophrenia are disorders of cognition, meaning they are something that individuals do or think. Examples include hallucinations, delusions, and bizarre or disorganized behavior. Positive symptoms can also be described as behaviors that indicate a loss of contact with external reality experienced by non-psychotic individuals. Positive symptoms tend to be the easiest to recognize. So, hallucinations, they involve perceiving a sensory stimuli that no one else is able to perceive. More frequently, people with schizophrenia hear voices that tell them what to do, warn of danger, or talk to each other about individual. Delusions include false beliefs that are not of the culture of the individual and are unchanging even after proven incorrect. So just remember, positive symptoms doesn't mean it's a good thing. Okay, positive does not equal to good. Positive means something is added to the behavior. Normally, people do not experience those symptoms, but in here, in people with schizophrenia, they have positive symptoms. It means that it is added to their behavior. So examples of it are hallucinations and delusions. So I have explained that hallucinations, these are sensory stimuli that we do not perceive. Okay, so the most common hallucinations is the auditory hallucination. So that's why during our MSE, when we try to look into the person's history, we try to ask them, do you hear something? Do you see something that we do not see? Okay, so you can put there with auditory hallucinations or with visual hallucinations. Okay, so delusions, on the other hand, these are false beliefs that are not of our culture and are unchanging even after being proven correct. So the difference between a firmly held belief versus a delusion is that in delusions, even though how much you convince a person that what they are believing in is not true or is false or seems to be bizarre or out of the ordinary, the person will not believe you. It's an inflexible belief compared to someone who has a very firmly held belief. So at least you can reason with them. They can still recognize what you are saying. They can perceive it. But in delusions, even though how much you convince that person that what they are believing in is wrong or false, so you cannot convince them otherwise, despite evidences. So there are many different themes of delusion, so I will explain them later. But now are negative symptoms. So negative symptoms, these are disorders of omission, meaning they are things that the individual does not do. Okay? So examples include alogia or lack of speech, flat affect, lack of emotional response, anhedonia, meaning inability to experience pleasure, asociality, lack of interest in social contact, avolition, lack of motivation, and apathy or lack of interest. So, a good thing to remember when it comes to negative symptoms is that they are always starting with the letter A. When you see there in your board exam or in your final exam that there is what are examples of negative symptoms, so just remember it is always starting with letter A. So alogia, flat affect, anhedonia, asociality, avolition. Okay? So some individuals experience catatonic stupor or a state in which they are immobile and mute yet conscious. So I will explain later on what is catatonia. So just remember, positive symptoms meaning something is added to that person's behavior that is not normal or that we do not do normally. Meanwhile, negative symptoms, something is taken out from that individual which the individual does not do, but usually people normally do. Okay, so positive and negative symptoms. Next, cognitive symptoms. So, cognitive symptoms prevent the individual from participating effectively in the workplace or in society. So, these are subtle differences in cognitive ability that are normally only discovered after a neuropsychological tests are given. So, these include poor ability to absorb and act upon information, meaning the executive functioning of the person is compromised, lack of attention, and an inability to utilize working memory. When we try to diagnose in general, we only not try to look in the MSC, but we also use psychological tests. And one way for us to know whether there are cognitive symptoms, especially in the diagnosis of schizophrenia, is through the neuropsychological tests. Okay? So, later on in our study in psych assessment, you will learn the different psychological tests that are used for neuropsych. Okay? So, this is also our way to know if there are organic causes of a certain mental disorder. So that's why in the DSM-5, there is always a specifier or another disorder that is called, for example, schizophrenia or psychotic disorder due to a medical condition. So we also take consideration the organic causes of certain disorders. So, like I said, the positive and negative symptoms are also further divided into motor disturbances, behavioral disturbances, and mood disturbances. Okay, so what are motor disturbances? So this include disorders of mobility, activity, and volition. So people with schizophrenia can exhibit too little or negative or too much or positive movement. So, in addition, catatonic stupor and catatonic excitement are examples of motor disturbances. So, this includes stereotypies or stereotypy, which are repeated non-goal directed movements such as rocking, mannerisms, which are normal goal-directed activities that appear to have social significance but either odd in appearance or out of context, such as repeatedly running one's hand through one's hair or grimacing. So we also have Mitkin, meaning moving a limb in response to slight pressure despite being told to resist the pressure. Echopraxia, which is the imitation of movements of another person, and automatic obedience. So, carrying out simple commands in a robot-like fashion. So, motor disturbances, these are in a category called catatonia. So, a person may experience both positive and negative symptoms and at the same time catatonia or motor disturbances symptoms. So, behavior disturbances. So, these are disorders of behavior that may involve deterioration of social functioning such as social withdrawal, self-neglect, and neglect of environment. So they involve behaviors that are considered socially inappropriate, such as talking to oneself in public, obscene language, or inappropriate exposure. Substance abuse is another disorder of behavior. Patients may abuse cigarettes, alcohol, or other substances. Substance abuse is associated with poor treatment compliance and may be a form of self-medication. So, as you can see, people with schizophrenia not only has those positive and negative symptoms and even cognitive symptoms, but also they tend to withdraw. They also tend to neglect their self, and of course, they neglect also their environment. That's why one of the misconceptions about mental disorder is that now that you learn more about mental disorders, we tend to see the typical stereotype or stigmas regarding mental disorder. And one of them is, of course, we often called the homeless people buang. The term that we called buang. So, we tend to associate it to people who are homeless. And let's consider that not everyone who is homeless is considered quote-unquote buang. But this is the typical stereotype that we often face. That's why when we say someone went to a mental hospital, they tend to tell that person that the person is buang. And buang, the term buang, is often associated to symptoms of schizophrenia. But now that we learn more about mental disorders, so the term buang is stigmatizing. The term buang is stereotyping people with mental disorders. So that's why if we can educate our loved ones about mental health, so the stigma, the stereotyping will be, of course, minimized. Okay, and more people will be informed about it. So especially this highly stigmatized and highly stereotyped disorder, which is schizophrenia. There are also mood disturbances in schizophrenia. So disorders of mood and affect include affective flattening, which is reduced intensity of emotional expression and responsiveness that leaves patients indifferent and apathetic. Typically, one sees unchanging facial expression, decreased spontaneous movement, a lack of expressive gestures, poor eye contact, lack of vocal inflections, and slowed speech. There is also a presence of anhedonia, or the inability to experience pleasure is also common, as it is with emotional emptiness. Patients may also exhibit inappropriate affects such as laughing at a funeral. So those are the different symptoms of schizophrenia, different classifications of symptoms. But just remember, the major ones are positive symptoms, negative symptoms, and cognitive symptoms. Okay? So I hope we are clear on that. Okay, so now let's proceed to the Schizophrenia Spectrum. So like I said, these are groups of disorders with different severity and of course the duration. That's why it's called a spectrum. So that's why schizophrenia is the spectrum of psychotic disorders that include schizophrenia, schizoaffective disorder, delusional disorder, catatonia, and of course other schizophrenia or psychotic disorders such as brief psychotic disorder and schizophreniform disorder. So in the previous DSM, the DSM-40R, schizophrenia was divided into subtypes: catatonic, disorganized, paranoid, undifferentiated, and residual. The purpose of defining these subcategories was to better predict what course a certain presentation of schizophrenia might take and what treatment options will be most effective. However, these are removed in the new DSM. Instead, schizophrenia is now understood as existing along a spectrum of psychotic disorders that include schizoaffective disorder, delusional disorder, and catatonia. Before I discuss the other disorders such as schizoaffective, delusional, and catatonia, let me first describe to you or give to you the diagnostic criteria for schizophrenia, schizophreniform, and brief psychotic disorder. So for schizophrenia, of course, two or more of the following, each present for a significant portion of time, during which a 1 month period or less, if successfully treated, at least one of these must be 1, 2, or 3. Number 1 is delusions, hallucinations, disorganized speech, grossly disorganized or catatonic behavior, and negative symptoms. B, for a significant portion of the time since the onset of disturbance, level of functioning in one or more major areas such as work, interpersonal relations, or self-care is markedly below the level achieved prior to the onset, or when the onset is in childhood or adolescence, there is a failure to achieve expected level of interpersonal, academic, or occupational functioning. So, of course, this is one of the important things that you need to remember. Continuous signs of the disturbance persist for at least 6 months. This 6-month period must include at least 1 month symptoms or less if successfully treated that meet the criterion A. This is the active phase symptoms and may include periods of prodromal or residual symptoms. During these prodromal or residual periods, the signs of the disturbance may be manifested by only negative symptoms or by 2 or more symptoms listed in the criterion A present in an attenuated form. For example, odd beliefs, unusual perceptual experiences. So, of course, we have the exclusion criteria. Schizoaffective disorder, depressive or bipolar disorder with psychotic features have been ruled out because, number one, no major depressive nor or manic episodes have occurred concurrently with the active phase symptoms. If mood episodes have occurred during active phase symptoms, they have been present for a minority of the total duration of the active and residual periods of the illness. Letter E, the disturbance is not attributable to the physiological effects of the substance or another medical condition. And of course, if there is a history of autism spectrum disorder or communication disorder of childhood onset, the additional diagnosis of schizophrenia is only made if prominent delusions or hallucinations in addition to other required symptoms of schizophrenia are also present for at least 1 month or less if successfully treated. So of course, we also have different specifiers. So first episode, currently in partial remission. So when we say partial remission is a period of time during which an improvement after a previous period is maintained and in which the defining criteria of the disorder are only partially fulfilled. First episode, currently in full remission. Full remission is a period of time after previous episode during which no disorder-specific symptoms are present. Multiple episodes, currently in acute episode. Multiple episodes may be determined after a minimum of 2 episodes. In particular, after a first episode, the remission and a minimum of 1 relapse. So there is also multiple episodes currently in partial remissions and multiple episodes currently in full remission. And there is also continuous and unspecified. So when we say continuous, symptoms fulfilling the diagnostic symptom criteria of the disorder are remaining for the majority of the illness course, with subthreshold symptom periods being very brief relative to the overall course. And of course, there is another specifier if there is catatonia, and we will discuss more about catatonia later. So we also have here brief psychotic disorder. So, like I said, schizophrenia exists in a spectrum, and usually the milder form of schizophrenia is what we call the brief psychotic disorder, or that's the first one that is being diagnosed if, for example, it does not meet the 6-month criteria of the schizophrenia disorder. So, the difference between brief psychotic disorder and schizophrenia is the duration only. So, take note of letter B. So, the duration of an episode of the disturbance is at least 1 day but less than 1 month. So, 1 day but less than 1 month. So, if it is more than 1 month, that is another diagnosis with eventual fall to return to pre-morbid level of functioning. Okay, so of course, the exclusion clause, which is it is not because of a major depressive or bipolar episode with psychotic features, okay, or another psychotic disorder, and of course catatonia, and of course it's not because of a substance or a medical condition. So of course there is also a specifier with marked stressors, so brief reactive psychosis. So if symptoms occur in response to events that singly or together would be markedly stressful to almost anyone in similar circumstances in the individual's culture. Also, without marked stressors, if symptoms do not occur in response to events that singly or together would be markedly stressful to almost anyone in similar circumstances in the individual's culture, and with postpartum onset, if onset is during pregnancy within 4 weeks postpartum. Okay, so like I said, another disorder that is within the schizophrenia spectrum is the schizophreniform disorder. The difference between brief psychotic disorder and schizophreniform disorder is what I told you, the duration. So which is letter B. Okay, criterion B. An episode of the disorder that lasts at least 1 month but less than 6 months. When the diagnosis must be made without waiting for recovery, it should be qualified as provisional. Schizoaffective disorder and depressive or bipolar disorder with psychotic features have been ruled out. So, and also it is not because of a substance or another medical condition. So this we have here, we specify if there is good prognostic features, meaning the specifier requires the presence of at least two of the following features: onset of prominent psychotic symptoms within 4 weeks of the first noticeable change in usual behavior of functioning, confusion or perplexity, good premorbid social and occupational functioning, and absence of blunted or flat affect. Without good prognostic features, the specifier is applied if two or more of the above features have not been present. And of course, with catatonia. So, usually, if you go to the psychiatrist and then there are active symptoms of schizophrenia, but it is not within 6 months, the experience is not within 6 months, so they put their schizophreniform provisional. Okay? So, but if the symptoms are still active after 6 months, so it would be schizophrenia already. So again, so just to summarize the difference between brief psychotic disorder, schizophreniform disorder, and schizophrenia is of course the duration. So for the brief, so it must only be within 1 day to 1 month. For schizophreniform, 1 month to 6 months. And for schizophrenia, it must be more than 6 months. Okay? So I hope we are clear on that. So now let's proceed to other forms of psychotic disorders. So the first on our list is schizoaffective disorder. So this is characterized by abnormal thought processes and dysregulated emotions. A person with this disorder has features of both schizophrenia and a mood disorder, but does not strictly meet the diagnostic criteria for both. So we have two types. The bipolar subtype is distinguished by symptoms of mania, hypomania, or mixed episodes. The depressive subtype is distinguished by symptoms of depression only. Common symptoms of schizoaffective disorders include hallucinations, paranoid delusions, and disorganized thinking and speech. So, the DSM-V distinguishes schizoaffective disorder from psychotic depression or psychotic bipolar disorder by additionally requiring that the psychotic condition must last for at least 2 continuous weeks without the mood symptoms, although a person may be mildly depressed during this time. 2 episodes of psychosis, an increase from 1 episode in the DSM-4, must be experienced in order for the person to qualify for this diagnosis. So, to differentiate schizoaffective disorder from bipolar or depression with psychotic features is that the person must have an ongoing active schizophrenia features for 2 weeks, even after the depressive or the bipolar episode. So what is schizoaffective disorder? So it is an uninterrupted period of illness during which there is a major mood episode or major depressive or manic concurrent with criterion A of schizophrenia. So note, the major depressive episode must include criterion A1, meaning depressed mood. Letter B, delusions or hallucinations for 2 or more weeks in the absence of major mood episode during the lifetime duration of the illness. Symptoms that meet the criteria for major mood episode are present for the majority of the total duration of active and residual portions of the illness, and the disturbance is not attributable to the effects of the substance test or another medical condition. Of course, we have the different subtypes, the bipolar type and the depressive type. So these subtypes apply if manic episode is part of the presentation, and major depressive episodes may also occur. Depressive type, this subtypes applies if only major depressive episodes are part of the presentation. And of course, with catatonia, and of course with specification if this is only the first episode, currently an acute episode, meaning the first manifestation of the disorder meeting the defining diagnostic symptom and time criteria, and an acute episode is a time period in which symptom criteria are fulfilled. First episode concurrently in partial remission. Of course, I have discussed what partial remission is. Just in summary, of the schizoaffective disorder. So, schizoaffective disorder means that you are experiencing active symptoms of schizophrenia, and it is also concurrent with your mood disorder. So, it means that even after a major mood disorder episode, you are still having active schizophrenia symptoms, which is of the criterion A. At least, of course, for 2 weeks. So, even after, for example, the major depressive episode, after 2 weeks after the major depressive episode has been concluded, there is still active schizophrenia symptoms. Okay? So I hope that's clear. The second one is, of course, delusional disorder. So this is a psychiatric condition in which a person presents with delusions but no accompanying hallucinations, thought disorder, mood disorder, or significant flattening of affect. Apart from delusions, people with delusional disorder may continue to socialize and function normally. Their behavior does not stand out as odd or bizarre. However, their preoccupation with delusional ideas can disrupt their lives. So there are, of course, different subtypes for delusional disorder. First, the erotomatic type or erotomania, delusion that another person, is often a prominent public figure, is in love with the individual. So like I said in the previous kamustahan session, I said that person with erotomatic delusion may say that, that artist, that Tom Hiddleston is in love with me and he will come to marry me, something like that. Another is grandiose type. So, delusion of inflated worth, power, knowledge, or identity. So, the person believes that he is Albert Einstein. The person believes that he is the sent messiah who will save all of humankind. Another is jealous type. Delusion that the individual's sexual partner is unfaithful when such is not the case. So, you need to also consider, of course, we have discussed in personality disorders, paranoid personality disorder. So, you must distinguish here if this is only just a delusion and not a pervasive or a premorbid delusional disorder, which is masked as a personality disorder. So, another is persecutory type, delusion that the person or someone the person is close to is being treated badly or malevolently. So, somatic type, the delusion that the person has some physical defect or medical condition. So, you also need to distinguish this delusional disorder from the somatic symptoms or somatic disorders that is also in the DSM. There's also mixed type, delusions with characteristics of more than one of the above types but with no single predominant theme, and of course, unspecified type, delusions that cannot be clearly classified into any one of the subcategories. So, to be diagnosed with delusional disorder, the individual's delusions must last for at least 1 month and cannot be due to the effects of the drug, medication, or general medical condition. Delusional disorders cannot be diagnosed in an individual's previously correctly diagnosed with schizophrenia. Auditory and visual hallucinations cannot be prominent, though olfactory or tactile hallucinations related to the content of delusion may be present. This is the diagnostic criteria. So, letter A, the presence of one or more delusions within the duration of 1 month or longer. And of course, letter B, the important criterion to rule out schizophrenia is that criterion A of schizophrenia has never been met. Hallucinations, if present, are not prominent and are related to the delusional theme. For example, the sensation of being infested with insects associated with delusions of infestation. Letter C, apart from the impact of the delusions or its ramifications, functioning is not markedly impaired and behavior is not obviously bizarre or odd. If manic or major depressive episodes have occurred, these have been brief relative to the duration of the delusional periods, and the disturbance thus is not attributable to physiological effects of a substance or another medical condition and is not better explained by another mental disorder such as body dysmorphic disorder or obsessive compulsive disorder. I have already explained what are the different specifiers for delusional disorder. But another important specifier here is that delusions with bizarre content. So these are delusions that seems bizarre if they are clearly implausible, not understandable, and not derived from ordinary life experiences. For example, an individual's belief that a stranger has removed his or her internal organs and replaced them with someone else's organs without leaving any wound or scars. So last part of the schizophrenia spectrum is of course catatonia. So catatonia is, broadly speaking, is any condition of abnormal motor activity thought to be caused by a psychiatric disorder. For example, individuals with schizophrenia can demonstrate manic patterns of repetitious movement with no purpose, compulsively mimic the sounds or movements of others, or maintain the same posture for a long period of time without moving. In the DSM-V, catatonia is not recognized as its own disorder, but rather is listed as symptom of other psychiatric conditions such as schizophrenia, bipolar disorder, post-traumatic stress disorder, and depression. I think that's it. That's the end of our module 6, part 1. We will still discuss a lot more about the different disorders. So the part 2 is sexual disorders, gender dysphoria, and paraphilic disorders. And I hope to see you on our next videos. So bye-bye!